So now we're going to talk about stable versus unstable signs and symptoms of shock. In doing ACLS, we got to determine whether or not this patient is stable or unstable. Now they can be symptomatic and be stable or unstable. With unstable patients, they're going to have more severe signs and symptoms. With a stable patient, we're going to follow more of a drug type of therapy or medication type of therapy. So that's going to be like your lidocaine or amiodarone, that's going to be your adenosine, that's going to be your atropine for your bradycardias. Whereas unstable patients are going to go with more of electrical therapy, in which we're going to do cardiac pacing, sync cardiovert, or unsynchronized defibrillation. And the way that we determine between stable versus unstable is following a mnemonic. We call this Chaps. And we made reference to Chaps in our previous videos about how we can be successful with static cardiology. So if a patient has any of these categories, and it just has to be one, we're going to classify them as unstable because these are all signs and symptoms of hypoperfusion or shock. So the first one, if your patient has chest pain, hypotension, a systolic blood pressure of less than 90, altered mental status or altered level of consciousness, flash pulmonary edema, or signs and symptoms of shock, we're going to classify them as unstable, and we're going to go with those electrical treatments. So chest pain. A patient that's having chest pain is caused from inadequate perfusion to the myocardium. It doesn't necessarily mean that they're going to have EKG changes, but the fact that they have some sort of chest pain with their cardiac event means that there's something going on and makes them classified as unstable. Hypotension, a systolic blood pressure of less than 90. Okay, that means that they're not getting adequate afterload or ejection of blood flow out of the heart to maintain a systolic blood pressure. And we all know that we need a systolic blood pressure of about 90 in order to perfuse the brain. If we have low blood pressures, then we might start seeing signs and symptoms of that hypotension. One of those being altered level of consciousness or altered mental status. Again, if we have a systolic less than 90 and we're not able to perfuse the brain, then we might start seeing some effects. Some confusion might start to set in. They may not be able to answer simple questions like being alert to person, place, time, or event. Next, we have flash pulmonary edema. And students sometimes get confused between the difference between flash pulmonary edema and chronic pulmonary edema. Chronic pulmonary edema is a patient who has like a history of congestive heart failure. Maybe they have swollen legs and they take some type of water pill like Lasix or furosemide for their condition. That's not what we're talking about here. We're talking about an acute onset right now that they get fluid buildup on the lungs due to inadequate pumping of the heart, would be what we would classify as unstable flash pulmonary edema. And finally, we're going to talk about signs and symptoms of shock. Okay, and all of these can be signs and symptoms of shock. But some other things that you might see can include shortness of breath, delayed cap refill, tachycardias, all showing that the body is trying to compensate and to you get that parasympathetic stimulation in order to try to maintain homeostasis and to maintain adequate perfusion throughout the rest of the body. Last of all, we have signs and symptoms of shock. Now, all of these that we've talked about can be signs and symptoms of shock, but there's also some additional things that might indicate that a patient's in shock. Things like shortness of breath, delayed cap refill, and tachycardia all can indicate that a patient is not perfusing well and their sympathetic nervous system is kicking in, trying to maintain adequate perfusion. So when we look at Chaps, if we see any one of these criteria, we are going to classify our patient as unstable, and we're going to go to those electrical therapies before pharmacology. If they don't have any of these signs and symptoms or signs of shock, then we're going to go with a stable form of treatment. We're going to do our pharmacological therapies first. And then if those don't work, then we may consider going to our electrical therapies. So to sum it all up, it's really important that you're able to identify a patient as whether or not they're showing signs and symptoms of shock. If a patient is in shock, we need to be aggressive with the management because the outcome for not treating a patient with shock can be very severe and they can decompensate very quickly. If they're not in shock and you treat a patient for shock, most people are going to be able to tolerate that well. You give them a little bit of extra fluid, unless they have some sort of condition where they already have wet lung sounds or they're having congestive heart failure or some type of enlarged heart problem. They should be able to handle a little bit of fluid resuscitation, oxygen therapy without any ill or adverse effects.